Good afternoon, everyone. And on behalf of the Colon Cancer Alliance, welcome to the second webinar in the new Colon Cancer Alliance's Conversations About Colon Cancer webinar series, which occurs every third Wednesday of the month from 7 o'clock till 8 p.m. Eastern Standard Time. This is a special webinar in the middle of the afternoon, and my name is Kevin Bergerson, and I'm a patient navigator and patient support and outreach advocate, and part of the wonderful patient support staff for the Colon Cancer Alliance. This afternoon's webinar is conducted in partnership with the Roswell Park Cancer Center out of Buffalo, New York. We have approximately 250 registered attendees, of which there's 55 on the webinar at the moment. We are very fortunate to have two top-notch presenters from Roswell Park Cancer Institute with us this afternoon, Dr. Amanpal Singh and Dr. Patrick Bowen, who will be providing you with information on the latest colorectal cancer treatments and trends, as well as highlights from the American Society of Clinical Oncological Gastrointestinal Conference held in San Francisco last month. After their presentations, we are going to be able to ask questions if we have the time. We envision this webinar to be interactive where you can do that. If we have that time, after both presenters have presented, please be prepared to ask your questions. We have a mechanism for you to do that. To submit a question for possible use, click on the small plus sign located next to the word questions on the webinar control panel located on the right side of your screens. Then type your question in and hit enter. Questions will be collected and asked on a time available basis, and my apologies in advance if you're unable to ask questions because we run out of time or if your particular question was not able to be asked. Our first presenter is Dr. Amanpal Singh, who is an assistant professor in the Division of Gastroenterology in the Department of Medicine, Roswell Park Cancer Institute. Dr. Singh completed medical school at All India Institute of Medical Sciences in New Delhi, India. He has a Master of Sciences in Epidemiology from the Harvard School of Public Health out of Boston, Massachusetts, and he went on to complete an internal medicine residency in gastroenterology and hepatology fellowship at the University of Texas Medical Branch in Galveston, Texas. Dr. Singh finished his training via Advanced Therapeutic Endoscopy Fellowship at the University of Texas MD Anderson Cancer Center in Houston. He has presented multiple distinguished abstracts in the field of gastroenterology and is a recipient of the American College of Gastroenterology AstraZeneca Fellowship Award and the American College of Gastroenterology President Poster Award. In 2013, Dr. Singh joined the faculty at Roswell Park Cancer Institute. And with that, I'm going to turn the webinar over to Dr. Singh for his presentation.
Good afternoon, everyone. I'm a gastroenterologist here at Roswell Park, and I'm going to be covering the basics of colorectal cancer and the prevention and surveillance part of it. I have no conflict of interest, and this material has been based on the guidelines from American Cancer Society and American Gastroenterology Association. So, starting from the basics, what is colorectal cancer? Colon is the last part of the GI tract, which starts from the terminal ileum and cecum and goes around our body into forming the transverse colon, the left side of the colon, and ending into the rectum here. The function of this part of our body is to absorb water and concentrate the stool material, as well as also act as a storage so that we can defecate at our own convenience. So when the cancer develops in the lining of the colon or the rectum, That is what we call as colorectal cancer. There are estimated 1,3,200 cases in 2015, new cases of colorectal cancer. This is the third most common cancer in the United States, and it's the second leading cause of cancer deaths when we put men and women together in the statistics. It is estimated that in 2015, around 50,000 people will die of colorectal cancer. So this shows the burden of disease in our country here. Who gets colorectal cancer? What are the risk factors? Smoking, like in many other cancers, is #1 risk factor for colon cancer. Heavy alcohol abuse, physical inactivity, obesity. The incidence of colorectal cancer can increase with age, especially after 50 years of age. Certain diets like red meat, processed meat, and low intake of vegetables, whole grains, and fruits are associated with high risk of colorectal cancer. The other risk factors in special scenarios include history of inflammatory bowel disease like ulcerative colitis or Crohn's colitis. Patients with family history of colorectal cancer are also at a higher risk of colon cancer. And then we have some rare inherited syndromes like FAP, Lynch syndrome, and Peutz-Jeghers syndrome, which increase the risk of colorectal cancer in patients. Many times when I do a colonoscopy and I come back and tell the patients I took out a polyp, and I'm often asked, what is a polyp? So polyp is an abnormal tissue that grows in the colon. It's benign and non-cancerous at this time, but it has the potential to become cancer. And certain types of polyps have more potential than the others one. So the polyps can be hyperplastic polyps, which are mostly considered to be benign, except in rare chances where it's in the right colon, tubular adenoma, tubular villus adenoma, and villus adenoma. The chance of becoming cancer increases as we go more and more towards the villus adenoma. So the goal of screening is to detect these polyps and remove them before they can become cancer. And also, by undergoing colon cancer screening, we are able to detect some patients with cancer at a very early curable stage, and they can undergo surgery or other treatments and it can be curated. Can colon cancer be prevented? The answer is yes, and that's what we are trying to increase awareness about, so that we can have good colon cancer screening rates and every patient can be screened, because this is a preventable cancer. By doing screening, we can detect pre-cancer conditions like polyps even among patients who have no symptoms and no disease. And the reason is the time interval that it takes for a polyp to become cancer can be 10 to 15 years. So we can use this time interval and remove these polyps before they turn bad on us. So what are the different screening modalities? The screening modalities, the first type of test that I'm going to talk about are cancer prevention tests. These can be endoscopy, like a sigmoidoscopy, where we examine only the lower colon, or it could be colonoscopy, where we examine the whole colon. Or it could be some radiology test like barium enema or a CT colonography. The other type of screening modality, a cancer detection test. These are mostly based off stool-based tests like the guaiac test or fecal immunochemical test or the stool DNA test. These tests mainly find cancer, but they can also find some large polyps. So let's talk about all of these tests in a little bit more detail. So first we will start about sigmoidoscopy. Here we insert the endoscope to the distal 40 centimeter of the colon, on the left side of the colon. Patients will need a complete or a partial bowel preparation. We generally don't use sedation for this, and this can be an office procedure. And because we're not using some sedation, then there could be mild discomfort. And the protective effect of sigmoidoscopy is only limited to the area that we see during the procedure. And if this is chosen as a screening modality, then it is needed to be done every 5 years. Colonoscopy. In this procedure, complete bowel prep is required, and we often use conscious sedation, almost always. Patients hence will miss a day of work and will need someone to bring them to the facility. And in average risk patients with a normal colonoscopy, we recommend every 10 years. Talking about a radiology test, there are these two types of tests, CT colonography, which is a recent advance, and barium enema. Even in these tests, we need complete bowel preparation. And if patient has one or more polyps which are more than 6 millimeter, colonoscopy will be recommended so that that polyp can be removed. And by itself, these can be done every 5 years for screening. So when we compare colonoscopy to radiology test, we find colonoscopy is more useful because you can detect and remove polyps at the same time. There is no need for repeat bowel preparation, because if radiology test shows a polyp, then you need a colonoscopy to repeat it, to take it out, and then that would mean patient has to undergo another bowel preparation. Colonoscopy is more sensitive in detecting small tumors, even smaller than 6 millimeter ones. And in colonoscopy, we are able to detect flat polyps, which are harder to see on barium enema or CT colonography. The bad thing about colonoscopy is that it's an invasive test, and there is a rare chance of complication, although the risk is very, very small. Stool test. These are cancer detection tests, and they are generally required annually if they are used as the screening modality. The interval for stool DNA is not yet certain because it's a recent advance. The sample may be required 2 to 3 times, but these should not be obtained by a digital exam because that can make the results false positive. And stool DNA is the most expensive of these. If any of these tests come back positive, the next step will be to do a colonoscopy for further evaluation. So, to summarize these tests, colonoscopy is the gold standard. And hence, American College of Gastroenterology recommends that this should be the first and best test to be offered to the patients. If for some reason patients cannot have a colonoscopy or do not wish to undergo colonoscopy, in that case, the other tests can be offered. So when to start colon cancer screening? At 50 years of age, and this is based on the epidemiological data, that average risk of patients can develop polyps starting at this age, and this is when the yield will be the maximum. However, in certain patients who are at high risk of colon cancer, especially who have first-degree relative with colon cancer, we want to do 10 years before the age of that first-degree relative that was diagnosed at the risk with colon cancer. So on the same lines, we are also finding more and more about young onset colorectal cancer. This is colon cancer which is diagnosed in patients who are younger than 50 years of age. The incidence of colorectal cancer in these patients have been decreasing. The top graph shows the risk of colon cancer in patients who are younger than 50 years of age. And the bottom graph shows that the risk in average risk patients who are older than 50 years of age. The risk in elder patients are going down because of screening majority. However, the risk in younger patients is trending up. Surveillance. This means repeat testing among patients who are at higher risk. And the test of choice for these patients is colonoscopy. This is primarily done in patients who are once diagnosed with history of colon polyps or who have had colon cancer and are currently surviving it. And we want to make sure they do not get recurrence of colon cancer. So the interval for surveillance depends upon the type, size, and the number of polyps. For example, if patients have 1 to 2 tubular adenomas, we can do it in 5 years with repeat colonoscopy. That's the recommended interval. If the count is more than 2, or if the polyp is bigger in size, we bring them sooner in 3 years. Any villus features, again, this is a high-risk polyp, and we would like to see this patient back in 3 years. If patient has too many tubular adenomas, more than 10, then the recommended interval is less than 3 years. When we talk about these recommended intervals, we assume that the bowel preparation was completely clean and we were able to remove and see all the polyps. However, the colonoscopist or the gastroenterologist may bring the patients sooner than this time interval if he was not satisfied with the bowel preparation. In patients who have history of colon cancer, they need to be also under surveillance with routine colonoscopies. And this is typically done after the cancer treatment surgery. The interval recommended is first colonoscopy should be performed 1 year after the surgery. The subsequent exam is in 3 years if the first colonoscopy is normal. And the subsequent exam should be in 5 years if the second colonoscopy is normal. Thank you so much for your attention. I will go back to Kevin.
All right. Well, thank you very much, Dr. Singh. I'm going to change it back over here to Dr. Balan while it's moving on over to his screen. Dr. Balan is our second guest presenter, and he's Assistant Professor of Oncology at the Department of Medicine at the Roswell Park Cancer Institute. Dr. Balan completed medical school at Jefferson Medical College of Thomas Jefferson University in Philadelphia. He went on to complete an internal medicine residency at Boston University Medical Center in Boston, Massachusetts, and he finished up his training via a medical oncology hematology fellowship at Fox Chase Cancer Center at Temple University Hospital. In 2013, Dr. Balan joined the faculty at the Roswell Park Cancer Institute as part of the gastrointestinal oncology team, where he works as a medical oncologist treating patients with lower gastrointestinal cancers. His clinical interests include colorectal cancer and the development of new cancer therapies. Dr. Balan, I'm going to turn it over to you, sir.
Okay, great. Hopefully you can hear me. So I am, as stated, a medical oncologist, so my purview of things is a little bit different. I predominantly see patients after the cancer diagnosis. Let me just mute this here. Okay. So what I want to talk about today, so one, I want to go over what some of the current standards are for treatment, and then some updates to that, and then break this down really looking at from not only from ASCO GI, but from the last year or so, some updates on treatment for early stage disease, and then also for late stage disease. So just to review again, so the way that we stage colorectal cancer, so in part has to do with whether there's lymph nodes involved or not, but also how deep the tumor is penetrating into the wall of the colon. So this here is a picture of the bowel as a tube, and then you can see blown up the differing layers. So the reason this is important is the deeper the tumors penetrate, essentially the more involved the treatment, going from surgery alone to surgery and chemotherapy, and it also gives some indication of the risk of recurrence down the road. So essentially looking at this, a stage 1 colon cancer, we think of in basic terms as a tumor that's just involving the inner layers of the colon and there's no lymph nodes involved. A stage 2 is one that's involving deeper into the colon, and it can extend to the outer layers around the colon, but still does not involve lymph nodes. A stage 3 colon cancer is basically defined as it can be any size tumor, but it is involving the lymph nodes around the bowel area that's involved, so the local lymph nodes. And then a stage 4 tumor is one where there are separate areas of involvement. So typically we think of that as being separate organs involved, like the liver or the lungs, but this can also be distant lymph nodes. So if enlarged lymph nodes in the chest, areas that are distant from where the primary tumor is. And so the reason this is important is because this really dictates what the treatment options are. So as a medical oncologist, I'm predominantly see patients with stage 2, 3, and 4 disease because most patients with stage 1 disease can be treated with surgery, and we do not have a surgical oncologist on this, but depending on the involvement in some very, very early tumors, a less invasive approach can be taken, but typically this does involve a resection of the bowel and having lymph nodes removed. So for going down the list, stage 2 colon cancers typically involve a surgery and possibly chemotherapy, depending on other factors. Stage 3 tumors as a whole, typically in someone who's in good shape, we look at surgery and then chemotherapy after the fact to reduce the chance of this coming back. And stage 4, on the other hand, we tend to put the chemotherapy as the first thing of order, and in certain cases, when there's a more limited amount of distant involvement, we think about things like surgery or radiation therapy. So for rectal cancer, it's essentially the same schema. The difference is that historically rectal cancer in the tight pelvic space has been plagued by a high risk of these tumors coming back right around the spot where they started, either within the where the rectum is reconstructed, or in the fat just around there. So the standard has become for patients with rectal cancer at stage 2 or 3 to receive radiation and chemotherapy initially, which is then typically followed by surgery, and then chemotherapy after the fact to minimize the risk of this coming back. There has been some data coming out in the last few years that in certain cases, the chemotherapy, instead of being given after the fact, can actually be given before radiation or surgery, and that this is safe to do and has some potential benefits, although it's not clear that this is better than the standard way of doing things. What we've also seen is that patients who have surgery and they don't find any tumor remaining, so they have what we call a pathologic complete response or a complete response, these patients have very, very good outcomes compared to everybody else. And really the problem now in rectal cancer is that one of our biggest risks is that these tumors will come back somewhere else, not the area where they started. So this has changed some things. So just wanted to talk about some things that were presented at ASCO GI this past month. So the folks at Sloan Kettering essentially presented their experience over the last almost decade with patients who had a complete response, a complete clinical response, we call it, after getting radiation and chemotherapy for rectal cancer. So these are folks where they get the treatment, they have a flexible sigmoidoscopy done, and when they look, they can't see any tumor left there anymore. There's no residual ulceration, there's no tumor whatsoever. And they compared these to so these 73 patients were managed this way over that time. They compared this to a group of similar number of patients who'd had surgery and found to have a complete response, a complete pathologic response. They were followed only about 3.5 years, although most of the time we would see recurrence at that point, probably about 80% of the time. And what they saw in these patients who actually were not managed with surgery, that 7% of them were able to go on without regrowth of the tumor in the area where it started. So that additional 23% of patients, when it recurred, they were potentially taken on for surgery, and all but one was able to be successfully pursued. So essentially 77% of patients remained okay without having a surgery, and the remaining 21 of the remaining 23% were able to be essentially salvaged, when something recurred. So this is encouraging. This data is consistent with other reports. So some of the original data from this came out of a Brazilian group with Dr. Habergama, and there's been reports from some other places. These are not what we consider to be the gold standard. So these good randomized studies, but that's not something that I think is going to likely be able to be properly done in this sort of scenario. So I think we have some mounting evidence to support that in certain select patients we may be able to approach things in a non-operative manner. I think we have to be pretty cautious in doing this because compared to the thousands of patients that were gracious to be on studies to essentially prove the mettle of our current therapies, we're looking at essentially dozens of patients who've gone through this. So this is a small number. This is not yet standard at this point. And I think it's important to point out that with our standard treatment, the chance of a tumor coming back around the rectum is actually very low. It's in the single-digit percentages. And that ultimately those folks who do go on to have non-operative treatment, up to a quarter or a third of them may require some surgery, and the risk is that they may require a larger surgery than what would have been initially involved. So requires a very careful discussion, and I think has to be only very selectively done. So I want to focus the remainder of my talk actually on advanced disease because that's more of what I tend to see. So I wanted to go over where standard chemotherapy stands, some of the data with respect to choosing the best chemotherapy regimen, and then some recent data on vitamin D, and a few new drugs that were presented recently. So we've come a long ways in colon cancer. So essentially, we started out really with one drug, 5-FU, approved what seems like eons ago now, and with time we've seen the approval of additional agents. So we now have irinotecan and oxaliplatin, which make up the FOLFIRI and FOLFOX regimens, along with 5-FU, and also subsequently had capecitabine approved, and this can be substituted in for 5-FU. So these are sort of the classic cytotoxic types of chemotherapy drugs, so the classic drugs when we talk about chemotherapy. Since that time, we've had the approval in the mid-2000s of some of the biologics for colorectal cancer. So this includes cetuximab and panitumumab that target the epidermal growth factor receptor. So this is one of the growth factors that is activated often in colon cancer, and also bevacizumab. And then there's been a quiet period with not many drugs being approved. But recently we have seen the addition of two drugs in the last 2 to 3 years. This is zivaflibercept and regorafenib within the last 2 years. And I think there's more on the way coming soon. Looking at, now that we have all these options, how do we choose what to start with? So essentially there was presented at ASCO last year this study, CALGB 8045. So essentially this is a study looking at patients with metastatic colorectal cancer, what chemo is the most appropriate to start with, and with what biologic agent. Because typically we combine our FOLFOX and FOLFIRI, the old chemo drugs, with these biologics. So essentially oncologists could choose the standard chemotherapy, FOLFOX or FOLFIRI, and as we know in the U.S., about 2/3 chose FOLFOX, and then they were randomized to get bevacizumab or cetuximab. So this is over 1,000 patients. And on this study, we saw that patients with stage 4 disease were living on the median about 2.5 years. So certainly patients living less than that. There was a proportion of patients who were living much longer than that. But this, I think, shows that we have been making some steady progress against this disease over time. So on this study of the 1,100 patients, about 11% of them were able to be rendered disease-free from chemotherapy and other treatments. And among these patients, the median survival was greater than 5 years. They had not actually reached the median survival there, which is very good. The important takeaways from this is that the chance of getting the tumor to shrink by a sizable amount from either regimen was very similar, actually, at least at this initial report. And the time that we were able to control the tumor, as well as the time that people lived with these treatments, were very similar. So in some ways, you may look at this as being disappointing, but I think it points out to us that we have made many options for initial chemotherapies. Essentially, they're equivalent in effectiveness with the current ways that we pick drugs, so that we're able to pick drugs and pick the regimens based upon the side effects and I think personal preferences of both the patients and the physicians. So I think this puts an onus on us to have a conversation about what are the pros and cons of the different drugs and options. So at this point in time, really the standard initial chemotherapies really most commonly are going to be either FOLFOX or FOLFIRI with one of the biologics, meaning, as I mentioned, either bevacizumab, cetuximab, or panitumumab. Really, any of these is acceptable at this point, with the caveat being that for cetuximab and panitumumab, it's been established that those patients who have a mutation on their tumor in KRAS, that they actually do not get a benefit from cetuximab or panitumumab, and they actually do worse if they receive those drugs. So it's imperative, and it's historically been imperative that we get KRAS testing before giving one of those drugs. As I stated, capecitabine can be substituted for at least part of the chemotherapy. So it's the nice thing is it's an oral option, and I think there are alternatives. I think for some patients, we do have the option of starting with a less aggressive treatment, something that's potentially more gentle but still provides a benefit with just the 5-FU or capecitabine, potentially with bevacizumab. And there's some mounting data that there may be actually a role for giving what's essentially the whole kitchen sink approach with FOLFOXIRI. So it's a combination really of all of the 3 classic chemotherapy drugs. The risk there is that you induce more side effects, and it's not at this point clear that for the average patient we're actually doing them justice in the long term. So one of the troubles has been, and the reason that we're sort of left with, what I talked about to pick drugs is a good predictor of benefit. So for the classic chemotherapy drugs, FOLFOX or FOLFIRI, there has really been no reliable predictor to indicate which patients are going to benefit from which treatment. And for the drugs that target, what we call the anti-angiogenics, the ones that target, we think, blood vessel signaling and blood vessel factors, so like bevacizumab and zivaflibercept, they're also frustratingly remain no means to predict benefit. I've already mentioned that for the anti-EGFR therapies, historically what we've seen a few years after these drugs were approved, that we found out that KRAS could actually identify those patients who would not benefit. So what's come out really in the last year, so historically, as I said, we have looked at the KRAS genes. So these are depictions of, so just kind of nice simple depictions of the KRAS and NRAS genes. So what we have found is that patients who have KRAS mutations that turn on this KRAS signaling, that they don't benefit from those drugs like cetuximab and panitumumab. And what's come out from a number of studies, one by one, is that when they looked at an expanded a portion of these genes of KRAS and NRAS, that it looks pretty consistently like if we find a mutation not only in that exon 2, but anywhere in the gene, namely in these other areas 2, 3, and 4, that patients are also not benefiting. So this is now really becoming the standard. So the old standard has just been testing one small part of the KRAS gene in patients with metastatic cancer. But I think with the mounting data, this is something that does need to be done. The patients who have newly diagnosed cancer should have this expanded KRAS testing as well as NRAS testing to determine whether they can receive these agents and potentially benefit from them. So it's important to note that these mutations are mutually exclusive, meaning if you have one of them, you're not going to have one of the others. So patients who've already been found to have a KRAS mutation and didn't have expanded testing, I don't think there's a role to go back and do more testing now. So just wanted to talk briefly about some of the new therapies coming along. So, but first, kind of an oldie. So, looking also at the study that I just mentioned, this CALGB 80405, where they looked at metastatic colorectal cancer patients, and essentially we're getting treatment of physician's choice. They looked at the patient's vitamin D levels, specifically the 25-hydroxy vitamin D levels in their blood before they started treatment. And what they saw really is that lower vitamin D levels co-segregated, so they were associated with patients being male, being black, living in the Northeast, having a higher body mass index, and a lower level of physical activity, among other things. When they broke them down by quintiles, so by fifths essentially, and they looked at the lowest 20% of patients and the highest 20% of patients, the median vitamin D levels, just to give you an idea, were around 8 and around almost 28. And across the whole group, there's a low level of patients who are using supplements, only about 15% in the highest vitamin D levels and only single digits, 3-4% in the lowest vitamin D levels, actually almost all the rest. So interestingly, what they saw is that those with a higher vitamin D level, that should say linked, so having a higher vitamin D level was linked to a longer survival, so even when they adjusted for other prognostic factors. So you can't control for all these things, but I think this raises a number of questions. One, are these vitamin D levels, is it the vitamin D that's responsible for this, or is it that the vitamin D is linked to some of these other factors, like some other lifestyle factors? A secondary question is if the patients who had low vitamin D levels had appropriate supplementation, would that improve outcomes? We really do not know the answer to that. And directly related to that is if that would be the case, how much vitamin D would be necessary? Again, we don't really know. So right now, this is not really ready for prime time. This is something that needs to be tested further. So vitamin D deficiency has classically been defined as vitamin D level of less than 20 nanograms per milliliter, and the optimal level is debated. Typically, it's thought to be at least greater than 20, although endocrinologists and some other folks have supported even higher levels than that as being optimal, greater than 30 or greater than 40. So at least some guidance. The Institute of Medicine at this point in time has essentially come out and said really the maximal upper level of intake that's safe, because vitamin D is fat soluble, so it can accumulate and essentially become toxic. The upper level is essentially 4,000 international units per day for adults. So there are no formal recommendations by any groups at this time, but I think it's an interesting piece of data, and I think for some patients, as this is being tested, it's something to think about anyways. But I would caution in taking mega doses of vitamin D. So another drug that's coming along is this drug called TAS-102. So really it's a combination of two drugs, and the first one is TFD, which is trifluridine. So it's a drug that is in some ways similar, works in similar ways to 5-FU. It appears similar to some of the building blocks of DNA, and it essentially disrupts the construction of the DNA by a couple different ways. So TAS-102 is a combination of the TFT and another drug that essentially increases enhances the way it works. So this particular drug is thought to have, the TBI is thought to have also some anti-blood vessel effects too. And at least when they looked in pre-human models, they saw that cancers that were resistant to 5-FU would actually respond when they gave TAS-102, which was encouraging. So it's a pill, and essentially right now the way it's given in 10 days out of a 4-week cycle. So these results were actually not they have not been presented at any large U.S. meeting as of yet, but they were presented at the European Society of Medical Oncology meeting last fall. And really what they saw was 800 patients with metastatic colorectal cancer that had really no standard treatment options left. And they were randomized to this drug or a placebo. And what they saw is that when they gave TAS-102, it prolonged survival. It was uncommon to see shrinkage, really less than 2%, and about 44% of patients had stable disease. The good thing about this drug is that as opposed to some recent drugs that have been approved, the side effects appear to be relatively limited. So the most common side effects were largely low blood counts. So things that typically we don't think of as making patients feel bad. So uncommonly, we're talking single-digit percentages, they saw more substantial nausea, vomiting, diarrhea, and the like. So it's currently, it's been granted fast-track designation by the FDA, and from the press releases, they have submitted this and they're awaiting an FDA decision. There are some ongoing expanded access studies, and I expect this is going to represent a new treatment for metastatic patients that will hopefully be approved later this year. So importantly, the efficacy appears to be at least as much as regorafenib, although they have not been compared, and there appear to be, at least on the surface, substantially less side effects. So I think this, when this drug is approved, I would expect that this drug is likely, if it appears how it seems, to take the place where regorafenib currently falls right now. One interesting thing is, as we're seeing this may work better than 5-FU, it would be interesting to see if these drugs work better with some of our other classic chemotherapies like irinotecan or oxaliplatin, or if they're used earlier on in treatment. So I want to leave a little time for questions, but I have a couple more. So Cyramza, which is ramucirumab, was also presented at the ASCO GI conference just recently. So this is an antibody. So it's a protein that blocks one of these blood vessel signaling receptors. So it's the VEGFR2 receptor. The reason I have this on here, on this picture on the right, you can see essentially one of the particular VEGF moieties, one of the particular types, one of these signals in the blood and around in tissue, can bind to the VEGF receptor, and it sets off signaling in cells to promote blood vessel formation, migration, growth, etc. So bevacizumab, which is already approved, blocks the circulating VEGF moiety, whereas ramucirumab actually blocks the place where that binds. So they're working in a similar way at slightly different places. If you look further down in the middle, we think that drugs like regorafenib and some of these additional agents that are being tested work also by blocking the VEGF receptor, just in a slightly different way on the inside of the cell, essentially. So Cyramza, or ramucirumab, was recently approved for stomach cancer, a place where bevacizumab was tested and did not have positive outcomes. It's a once every 2 weeks intravenous drug. So essentially, what the results were from ASCO GI, there was a large study conducted where they looked really at patients with metastatic colorectal cancer who had one previous chemotherapy with bevacizumab or Avastin, and they gave them essentially FOLFIRI with ramucirumab or just FOLFIRI alone. So this is the same way that bevacizumab has recently been tested, and the same way, pretty much that aflibercept has been tested. So they saw when they did this that it improved how long patients lived, even though a large portion of patients went on to get additional treatments after this. It did not change the number of tumors that shrank with this therapy. Fortunately, the side effects were only slightly different between the patients who got FOLFIRI and those who got FOLFIRI and the ramucirumab. And this was dominated really by high blood pressure, a slight increased incidence of low blood counts, and slightly more fatigue. So the difference, or actually, so at this point, from what I understand, the company who makes this drug is seeking FDA approval for use in second-line colorectal cancer. I think the real question is, where does this fit in? And I'd say, to me, it's not clear at this point. The difference that we saw in survival is actually almost identical to that we already saw with bevacizumab and aflibercept. And at this point in time, it's more than 2 times as expensive as these other drugs that are already approved. So without some way to pinpoint which patients would benefit, I'm not sure it actually really fits in at all yet. So there are multiple additional agents in testing, and many of these are ones that work in similar ways to drugs that have already been approved and work against some of these angiogenic pathways, so some of the blood vessel signaling type pathways. One of them presented at ASCO GI was famitinib, had encouraging early study results. It's another pill, and there's another drug, nintedanib, that's actually just been approved for a lung condition, non-cancer lung condition, and there's an ongoing international study looking at this in a similar place to regorafenib and TAS-102. So there are multiple things along in the pipeline, and I certainly can't cover them all today. Immunotherapy, one of the areas that's garnered a lot of interest in the last few years, is still early in evaluation in colorectal cancer, and it remains an unfulfilled promise, but hopefully this will be one that sees some successes soon. So I think at this point, the future directions for the field, at least for us, is really to look at expanded mutational analysis of tumors to hopefully identify which treatments are better or which treatments should be chosen up front. And hand in hand with this, there are more targeted therapies coming along. I did mention there's some extremely encouraging data for combinations targeting patients with BRAF mutant tumors, which tend to be among the more aggressive tumors when they're metastatic. And I think another point here is that we do need to continue and further evaluate some of these non-chemotherapy drugs that appear to have benefit in this disease. The group at Dana-Farber who did the vitamin D analysis is currently well on the way in conducting a study looking at chemotherapy with vitamin D. I think a lot of these things hopefully will yield some fruits in the near future. So that is the end for me. Thank you.
All right. Thank you, Dr. Bawan. I'm going to switch it back over here. We have a number of questions that have come in, and we'd like to have the opportunity here to get those addressed. If we got a few minutes here. We received a question from Laura, and I would like to caveat that if it's within your area of expertise, please we can try to address the question. We have a number of questions, so we'll try and spend about a minute or two on each question at the most. Let's try and get as many questions as we can. First one is from Laura. She says she has an ileostomy reversal in May 2013 after a bout of rectal cancer and is still suffering from cluster movements. Do you have any advice?
I'm sorry, from what movements?
Cluster movements.
Oh, okay. So I assume these are kind of fits of bowel movements, diarrhea. So yeah, so they're Aman, I don't know if you have any good tips here. I'm happy to give a crack at this as well. And we frequently do see folks have either hopefully temporary, sometimes some permanent bowel irregularities after resections.
Okay. I have another question here.
Oh, sorry.
Go ahead. If there's another question here from Eric is, what are the implications of cancer that has invaded the omentum, and what can be expected in terms of treatment?
Okay. So, yes, this is more up my alley. Yeah, so we think of the omentum as being, it's within the belly and it lays on top of the bowel, but we think of it as being a distant site. So we typically call that a stage 4 cancer. There are some centers and some places where if a cancer is confined only to the omentum or only to the peritoneum, where we sometimes debate whether a more extensive surgery, such as a high PEC, something on those lines, is appropriate. Typically, that was undertaken with the course of chemotherapy, often before embarking on that. But it really depends on the particular case.
Okay. All right, Dr. Singh, we have a question for you. Is there an age that people should stop being screened?
That's a good question. So the recommendations from American Gastroenterology Association and the United States Public Services Task Force recommend that, in general, we should continue to screen until the 75 years of age. And between 76 and 85 years of age, it depends upon how an individual is doing. If we think, the thumb rule is, if we think this person has 10 good years of life left, then we should do a screening colonoscopy till 85 years of age. So if you think someone's going to be around 95, 97, yes, this person needs a colonoscopy for screening till 85 years of age. After 85, we stop screening because the advantage that we get out of removing polyps is not anymore left. Because these polyps typically take 8 to 10 years to become cancer, as I said, so we can wait, and we don't need to worry after 85 years of age.
All right, thank you. We've got just 5 minutes left. We're going to try and get a few more questions in. This one is from Matthew. For a T1N1 patient who was given 5-FU but not oxaliplatin after surgery, what are the long-term risk factors for only receiving one drug instead of a combination of the two?
Okay. Yeah. So right. So a T1N1. So I think, as I tried to point out in there, so that would be stage 3, essentially because of the N1. D, meaning lymph node involvement. So fortunately, so a T1N1 really is a 3A cancer. So looking at the guidelines for and what we typically do in practice for stage 3 cancers, we would think about giving Folfox or capecitabine and oxaliplatin most commonly. Though really, if you look at the statistics that are available in a lot of places, patients with stage 3A cancers actually have a substantially better prognosis. So even better than those with so better than those with a 2B or 2C, and in fact approaching some of the earlier stage 2 cancers. So difficult to exactly answer the question, what are the long-term implications? But I think in some cases, so I think the standard is still to think about Folfox, in a healthy patient, but I think it can be questioned based on the better prognosis and the likely lesser absolute benefit. Something we didn't really talk about is, we know that there are very good linkages that folks who maintain a high level of physical activity. We're talking something in the order of 150 minutes of vigorous exercise per week, moderate or vigorous, that they do better in the long term. So I think some of these things are part of, or they should be part of our standard recommendations for patients, maintaining a healthy weight, staying physically active, and I think maintaining regular follow-up are part of the way that we try to reduce the risk of recurrence and or catch these things early if they do come back.
Okay. Thank you very much. You might be able to get a couple more in here. I do have a question from Christina. She asked, not being a clinician, is it appropriate to say that a stage 3 colon cancer patient undergoing chemotherapy with FOLFOX might have a greater benefit if a biologic was added?
So in theory, you would think so, right? So we know, one of the frustrating things in this field has been when we've looked at metastatic cancer, we've seen when we add biologics to FOLFOX, we increase the chances of response, we improve how long patients live, but we've actually, fortunately or unfortunately, done the studies to see if we give patients FOLFOX or FOLFIRI, other agents, and add Avastin or Erbitux to them, do they do better? And the answer is resoundingly no. So unfortunately, or however you look at it, the only agents right now that we know, chemotherapy-wise, that reduce the risk of recurrence really are 5-FU and oxaliplatin and FOLFOX, or capecitabine, which I think can be substituted for 5-FU.
Okay, we're almost out of time here. I have a question from Jean. What is dovitinib? It's currently in a phase 2 trial. Do you have any information on that, Dr. Bowen?
Dovitinib?
Dovitinib.
Yeah, so dovitinib is another one of these, I don't remember who makes it. It's another one of these small molecule inhibitors. So it's similar to drugs like, at least in some ways, it's similar to drugs like regorafenib, sunitinib, those drugs. So it's a pill, and it targets some of the signaling on the inside of the cells. So dovitinib is another one of these anti-blood vessel, anti-angiogenic agents, and it targets, one of the things that makes it different is it targets this FGF, this fibroblast growth factor receptor. It's another thing, it's one that we think is able to allow cells and tumors to get around resistance to anti-angiogenic therapy, so treatment like bevacizumab and whatnot. So it's been investigated for a number of cancers.
Very good. Thank you. Dr. Singh, I have one more question for you. If one has a family history of colorectal cancer and wants to get screened, could this be done in their 20s and 30s? If so, what can someone do to get this approved? The questioner works at a government-run hospital and is trying to get screened because of the family history.
So the recommendation in this kind of case will be to do screening 10 years before the age of the relative. Like if, say for example, the family member, first degree relative, developed colon cancer at the age of 40, so the person who's interested in getting the screening should get at the age of 30, so 10 years before the age. I don't think doing it any sooner than that will help more. So, but now the second part of your question was how to get this approval. Insurance companies will agree. What it would need will be something like a referral from your primary care doctor, and because of your family history of colon cancer, this will need a phone call from your doctor, either your gastroenterologist or your primary care doctor, to the insurance company and explain, hey, we have this person who's at high risk, and we want to be on top of the game. We want to screen him so that he doesn't develop colon cancer like his family member. So, and this is within the guidelines, so this should be easy to approve.
All right, thank you, Doctor. We're getting real close. We're at the 2 o'clock hour, and we're out of time for our particular webinar. But before we end the webinar, I want to thank everybody for their questions. We tried to get as many of those in as we could handle. We want to thank all the attendees for being here. Please don't forget to join us at our next week for our third webinar in the New Colon Cancer Alliance's Conversation About Colon Cancer webinar series, What You Need to Know About Social Security Disability. That'll be on February 18th at 7 p.m. Eastern Standard Time. On behalf of the Colon Cancer Alliance and for all of our webinar attendees assembled online today, I wish to personally thank our two speakers for their presentations. I know how busy you are, but we sincerely appreciate your time this afternoon. Thank you, Dr. Singh, and thank you, Dr. Boland.
Thank you.
Yeah, thank you.
Thank you, everyone, for attending our webinar. We hope you enjoy the webinar. Thank you for logging in today by phone and online. We hope you found it informative and value-added. There was a number of questions if this was recorded. Yes, it was. As a reminder, this webinar can be viewed the day following the broadcast on our Colon Cancer Alliance website at ccalliance.org/webinars. All registered attendees will get an email tomorrow with that particular link. And if you'd like to share your comments about the webinar, please forward your comments to me, Kevin Bergerson, at kbergerscn@ccalliance.org. That's in a lot of your emails that you received when you registered. We'd like to hear your feedback by email on this particular conference. Thank you, everybody, for attending, and we look forward to having you in our webinars in the future. Thank you very much. Have a great day, and thank you again for joining us.